Okay. Good morning, everyone. Thank you for bearing with us for some technical difficulties. I'm Gillian Shaw. I'm one of the pathologists here in Coplow, and I will get started with today's cases. Okay. First case is a dog. This is a globe from a 3-year-old intact female English Spaniel, which I had to Google. And the only thing I came up with was an English Springer Spaniel. So I'm not entirely sure if I'm picturing the right breed, but whatever, it doesn't matter. So the history we got was panuveitis with 4+ flare/cell, exudative retinal detachment, focal gray tan exudate also visible in the anterior vitreous, and the eye is blind with negative menace, dazzle, PLR, consensual and indirect PLR. The other eye was completely normal. They reported no glaucoma. The IOP was 14. They said it was present for about a month, these problems. And then they also say the patient was recently diagnosed with kidney disease with mild elevations in BUN, creatinine, SDMA, and urine-specific gravity was 1010. And they don't know the cause of the renal disease. They also say the patient spends a significant amount of time outside, hiking in woods, and swimming. So here's the globe. Cornea is always at the top of our gross photos. So we've got the cornea up here, relatively normal. The anterior segment really is relatively normal. There might be a little bit of gelatinous, proteinaceous material in the anterior chamber right here. The lens is right here. And then when we look at the more posterior parts of the eye, we start to see some sort of material piled up on the ciliary body surface on both sides of the globe. And then we come back into the vitreous. The vitreous itself is a little bit cloudy. The retina is detached and maybe a little bit thickened. It's kind of hard to tell. And then we also have some white material that's piling up on the surface of the exposed surface of the choroid because the retina is detached. And then the subretinal space also contains a little bit of cloudy material with maybe a little bit of hemorrhage. You can see a few little brown areas here. So those are the main gross findings. So now we will go to the histopath. Okay, so here's our globe. Now the cornea is off to the left here. So there's the cornea. There's that proteinaceous material I pointed out that's in the anterior chamber. And as we move backwards, here we see more of that proteinaceous material that's in the vitreal space, as well as the subretinal space. And then we have quite a bit of exudate that's piling up along the surface of the retina. So that is, well, it's some sort of cells, but I'll tell you right now, it's an inflammatory exudate. The lens itself was within normal limits. So the retina is obviously diffusely detached. And even from this magnification, we know that's a true retinal detachment because there is material in the subretinal space. So you always have to figure out if your retinal detachment, quote unquote, or separation is artifactual or true lesion. And when you have something in the subretinal space, that tells you right away that it's probably true. Okay, our extragonio slice in this case is actually pretty boring. So we're going to jump to higher mag here. There needs to be open. All right. Okay, so once again, cornea is off to the left there. The stuff in the anterior chamber is pretty boring. It's more of a homogeneous proteinaceous fluid. And as we move back, here's more of that proteinaceous material. Some of it gets a little bit fibrillar in the posterior segment, so that's probably consistent with fibrin. And as we move back here and check out our retina, so we start to see a lot of cells in the subretinal space, including some red blood cells. And as we go higher mag, we'll figure out that these guys are a bunch of neutrophils and also macrophages. So these guys are neutrophils with the little squiggly nuclei. This bigger guy is probably a macrophage. It's got a little bit more cytoplasm and kind of an oval to round to oval nucleus. And then all of the brighter pink are red blood cells, some of which have been probably phagocytosed by the hungry macrophages. at slightly lower mag, we can see the retina is also infiltrated by some plasma cells and some lymphocytes. And other than that, it's kind of normal-ish. And then when we move into that exudate that was in the vitreal space, right in front of the retina, what we have here is a lot of degenerate, inflammatory cells. So all of these guys with the really ghosty nuclei, really pale, ill-defined nuclei are necrotic. And yet we still also have a bunch of intact neutrophils and macrophages, like this guy right here. So we've got a mix of neutrophils, macrophages, which makes it pyogranulomatous inflammation. And I stared at this material for a long time because I was like, there's got to be some sort of infectious organism in here. I wasn't terribly successful, but I did find these areas right here. And I was seeing these sort of vaguely linear structures that were outlined by this deeply basophilic material. So this isn't really spot on for anything in particular, but something linear that's in the vitreal space with a lot of neutrophils and macrophages is somewhat suggestive of fungal hyphae. In the eye, for whatever reason, I don't think we know the answer. Whenever we have fungus in the eye for a certain amount of time, Splendor-Hopley reaction will occur. So you'll get deposition of stuff on the surface of fungi. And in the eye, for some reason, it's often deeply basophilic, just like this. So my suspicion was that there were fungal hyphae in this globe. So I ordered a fungal stain, which I will show you in a moment. But I also wanted to show this plaque back here. Oops, focus, Gillian. On the choroid. Yeah, so this is a beautiful fungal plaque. Sorry. There are fungus in here. There are fungi in here, excuse me. I'll show you. They're actually really hard to see on the H&E. But what I also wanted to point out, so here's the choroid. This is a blood vessel that's in the choroid. What we're seeing here, all of these bigger cells that are like with this kind of vacuolated cytoplasm, this is actually the tapetum. So these are tapedocytes, which are part of the choroid and what confer the reflective part of the dog's fundus. So we have a bunch of neutrophils here, and then these are sort of sheets of epithelioid macrophages. I found it really hard to find the fungal hyphae in here. Somebody's pointing something out from the audience, but
No,
okay. I will show you, when I show you the fungal stain, you'll be like, wow, they're really hard to see. Maybe things like this vaguely make you think of fungus when you know what you're looking for. But yeah, they're just really hard to see. But anyway, this is an interesting little sort of granulomatous plaque on the surface of the exposed surface of the choroid. The question was, are there fungi in the vessels? And yes, there are. I will show you. So those would be the vessels of the choriocapillaris when we get there. So here's the optic nerve. The optic nerve head is a little bit distorted by the detached retina. They did not report glaucoma. So we wouldn't necessarily expect decreased numbers of retinal ganglion cells or optic nerve head or optic nerve atrophy or gliosis. So those are the main findings on the H&E slide. Now we'll just skip right to the lovely PAS stain to show you the fungal organisms. So I'll show you them first in that choroidal plaque. So the counter stain here is green. So pretty much everything is green, and then fungi should be pink. Look at them all. So we've got all these linear fungal hyphae. The morphology is a little bit easier to see through the scope. I thought they were occasionally septate, and they're probably somewhere between 2 and 4 microns in diameter. I don't remember if I saw branching or not.
right angle.
Right angle branching.
So maybe 2 overlap.
Yeah, maybe right here.
In other areas, there's very
Okay.
90 degree.
Okay, so we have some right angle branching. And then, so Dr. Gasper asked if they were in blood vessels, and I spent a long time looking for them. I'm pretty sure this one right here is in a blood vessel. And so is this one who's right down here. So I think these are in blood vessels. Presumably these are in the choriocapillaris, which is the blood vessel bed, the capillary bed that's just under the retinal pigmented epithelium, which the vessels of which lead up into and help to supply nutrients and take waste away from the retina. So presumably this is a bloodborne or hematogenously spread fungal organism. Aspergillus loves to be vasculo invasive and like to come out of blood vessels into various parts of the body, including the eye. I don't actually know what species of fungus this is. So here's that exudate in the vitreal space, and you can see just how many fungal hyphae there are. They're just everywhere. So I'm kind of a wuss, and I don't really like to try to speciate fungus on H&E or by morphology, I should say. Doesn't matter what stain you're looking at. But Aspergillus is one that's commonly known to be hematogenously spread from elsewhere in the body and arrive in the eye. And there are others, including Fusarium. And that's about as far as I'm going to go. It's a non-pigmented fungal organism in this case. And that's all I'm going to say. So I assume that this is a systemic disease. And I also assume, obviously we don't know, but I assume that the renal disease in this patient could be also due to fungal disease. So Aspergillus and others like Fusarium are ubiquitous in the environment. So it's not necessarily, they're everywhere and around the entire world. So anyone is exposed to them probably constantly, and including dogs. And we know for a fact that young female German Shepherds are sort of more exquisitely or more commonly diagnosed with systemic aspergillosis. In this case, it's a young female English Spaniel, whatever that is. So I think there's something to the sex of an animal and as well as the breed. With German Shepherds, I assume it's some sort of innate immune problem or genetic, I should say, not necessarily implying innate part of the immune system, but some sort of genetic problem that makes them unable to mount an immune response to this very commonly encountered fungus. So my diagnosis here, most importantly, was marked suppurative and histiocytic endophthalmitis with intravitreal fungal hyphae. And so I'll call this a fungal vitritis. So I don't have any more follow-up on this dog. Hopefully they have started antifungal treatment. When I was actually previewing a flat of cases and ordering deepers and specials and stuff, I looked at this case and I thought, I think there's fungus in here. So I really quickly sent a preliminary report to the clinicians, knowing that I might not get to write the final one for a couple days, just to let them know. But I have heard no feedback or follow-up rather. Okay, cool. So that's a nice tidy one. Anything else to add? Any questions?
The only thing I 100% agree with you about identifying fungal organisms or microorganisms in general histologically can be problematic. There's this one interesting paper from the human literature where they got all the cases that they diagnosed, that they identify this type of hyphae, so hyaline hyphae with parallel walls and septating, hyaline meaning non-pigmented. And then they compared to cultures, and the vast majority were either Aspergillus or Fusarium. There's a whole list of other ones that can, of course, be there, like Pseudoschleria. There's a humongous list, but like about more than 70% of them were either one of those. Still doesn't get you, final speciation, but it at least helps.
And this one, the right angle branching was really prominent in a couple of areas, which would take Aspergillus off my list because it does acute angle or dichotomous branching.
Okay. Dr. Gasper piped up and said that right angle branching does not occur in Aspergillus. And so that would decrease or make it less likely to be Aspergillus in this case. I usually think of Aspergillus as being a little bit thicker too. Yeah.
And chronic infections, like we'll see animals that have been treated long-term with Aspergillus, they'll be bulbous and like there's like a 15 or 20 time difference in hyphal to hyphal size.
Okay.
It's not predictable, I don't think.
Okay. Cool. All right. Not cool for the dog, but cool for us pathologists. All right, moving on. Next case. Okay. This is a globe from a 12-year-old domestic short-haired cat, neutered male. The history we got was glaucoma, and they wanted to know if it was primary versus secondary, and if it was secondary related to cataract versus mass. They knew there was a detached retina, there was a corneal ulcer, and a mature cataract. So apparently a detached retina was diagnosed back in 2020. Cataracts were diagnosed in 2022, and then glaucoma diagnosed in 2025. The cat also has chronic kidney disease stage 3 and a heart murmur grade 1. So here is the gross picture of the globe. Once again, cornea is at the top. Right in the center, well, center sort of at the front is the lens, and it's slightly opaque, so that or it is opaque, and that is consistent with cataractus degeneration. There is obviously a lot of hemorrhage in this eye in all chambers, so there's some sort of hemorrhagic fluid in the anterior chamber, posterior chamber, and then in the vitreous. And actually, the vitreous is right here. This is the detached retina. And so what we're seeing here is a lot of hemorrhage in the subretinal space. And then what we see, which is fairly prominent, is this big white mass that is sitting right in front of the optic nerve. So there's the optic nerve at the bottom. And those are, oh yeah, this is also curious. So the iris leaflet is here on this side. And on this side, it's actually really hard to make out. So there's actually something going on with the anterior segment as well. And keep in mind that that iris leaflet was really difficult to see grossly. Righty. Always hard to know where to focus in this, doing this method. Okay, there's the cornea. It's pretty boring itself, or at low mag rather. As I pointed out on this side, the iris leaflet is really hard to make out. We can see the ciliary body here, but then we don't really have an iris leaflet to correspond to it. There is hemorrhage in all of the chambers, as I mentioned. There is some cataractus degeneration, so we'll take a higher mag look at that in a moment. And then as we move back, here's our mass. So there's the optic nerve. Here's the mass that really is sitting right in front of the optic nerve. This is some of the mass as well. And then what we're seeing here is, I think, retina there. And then we don't really have retina. I think this, oh, I can't remember. This might be some retina there against the back of the lens. We'll confirm that. Okay, and then also when we look at our little tiny gonio slice, which is an orthogonal section of one of either the cap or the second half of this globe, you can see that once again that iris is really kind of pushed right up against the peripheral cornea. So there's some anterior synechia there as well. All right. Let's just start with the mass because that's
cat, right?
Yeah, this is a cat. Okay, we're gonna start with the mass, just because. So from low mag, hopefully you can appreciate the really prominent vasculature of this mass. And then as we start to go higher, we have a neoplasm that is composed of spindle cells that sort of make up these funny little structures. I don't really have a good name for them. Bundles? I don't know.
Yes.
Nests? Okay, we have nests, bundles, I don't know. And when we go higher mag, their cellular and nuclear features are relatively bland. So we have, I presume they are spindle shaped. Some of them might be polygonal, but one of the more salient features here is that you can't really see their cell borders very well. So they really do not have distinct cell borders. Their nuclei are round to oval to elongated, maybe with some finely clumped chromatin and single, somewhat prominent nucleoli. The vasculature, as I said, is pretty prominent, and you can see how many little blood vessels there are around with this mass. The mitotic rate is relatively low. And I personally felt that the anisocytosis and anisokaryosis were relatively minimal to mild. So the features of these cells are kind of bland. And when we see a neoplasm with these features that is probably affecting the central retina, and when we look lower mag, as I said, it was sitting right in front of the optic nerve. So the retina would have been here somewhere. And as we follow it around somewhere,
That's hot.
yeah, there's definitely some retina here. Hold on. And I was correct. This is retina here. So this is very degenerate or gliotic atrophied retina, probably due to mostly probably due to being detached for a very long time. Remember, they diagnosed retinal detachment in 2020 in this case. So this mass in this location with these with this pattern and cytologic features is consistent with a glioma of some sort. And I will never take it any further than that. Pretty much because I'm a wuss. So we see these more commonly in dogs than in cats, which makes this kind of a unique case. I'm sure I've seen one before in a cat, but it's been probably quite a while. And basically, the most important, so if this were in the central nervous system, the ones that we see in the retina and optic nerve or optic nerve head would often be classified as one of the more aggressive varieties if it was seen in the central nervous system, like a higher grade, less well differentiated, for example. However, which in the CNS would impart a poor prognosis. In our experience, if it was removed completely, meaning it did not affect the optic nerve and extend to the surgical margin of the optic nerve, then generally speaking, these don't metastasize. And once you've removed it with clean margins, the prognosis is pretty good. So other than the really prominent vasculature here in the optic nerve, I did not feel that it was infiltrated by this neoplasm. I think what we're seeing here is probably fairly atrophied optic nerve tissue, but I did not think that there were neoplastic cells here. So I offered a pretty good prognosis for this patient. And presumably this thing has been growing for a long time, considering that the retina has been detached since 2020. So yeah. And I would assume that the neoplasm itself is the source of the intraocular hemorrhage. It could have also come from the detached retina as well. So now let's go back up to the front of the eye because there's some other interesting stuff going on here. And we'll start right down here. So we're getting, this is the limbal sclera. And one of the, here we go. So what we see right here is a fairly blunt end of Descemet's membrane, right up there. So Descemet's membrane, and whenever you see a blunt end of Descemet's membrane, it's pretty consistent with a break in Descemet's membrane of some sort. And then whenever we see breaks in Descemet's membrane that are peripheral, i.e. on the sort of periphery of the cornea, we consider those to be the result of blunt trauma. So personally, I believe this eye was probably blind for a long time. And whenever you have a blind eye, you're less able to protect from trauma. So I think probably this cat ran into something or was hit by an object of some sort, hopefully accidentally, that led to peripheral breaks in Descemet's membrane. And then in this case, this sort of broad anterior synechia. So what we're actually seeing here is the iris. There's some iris epithelium there. And if we looked more closely, we'd probably find some of the muscle. There's some of the muscle right there. Anyway, so I think this eye probably also suffered blunt trauma, which also could have been the cause of the cataract. So we're not going to spend much time, but what we see here is wrinkling of the lens capsule slightly, and then degeneration and liquefaction of the cortical lens fibers. So we've got a cataractous degeneration as well. So kind of an interesting long history for this case, and pretty tidy diagnosis, in my opinion. So most important, this retinal / optic nerve head glioma with clean margins, and then a bunch of other stuff going on as well, including results of blunt trauma. So that's all I'm gonna say, and I've already taken too much time. So
for the pathologists out there regarding the classification of these gliomas, if you try to apply the available classification, both like the WHO classification and what we can see on the literature in the veterinary medicine, the optic nerve retinal gliomas, they will almost always, well, they often fall into high-grade mixed glioma, meaning, they have features of malignancy, that's why a high grade, and the cellular morphology is often a combination of astrocytic with other types of glial cells. Most often than not, the majority of the cells are astrocytic in nature, and we have a very few cases where we end up calling, glioma / oligodendroglioma because they have oligodendroglial differentiation. But if you try to use that, you're most often going to end up with a mixed high-grade tumor, which Guillermo already explained. The high-gradeness here should be taken with a grain of salt.
Circumscribed.
Yep. By the sclera.
All right, so this is Kelsey. I'm going to do the next two cases. They're pretty short and sweet. So the first one is the eye from a 9-year-old female spayed terrier mix who presented to the ophthalmologist due to exophthalmos of the left eye, which is this eye we are looking at right now. The ophthalmologist noted that the globe resisted retropulsion, but there was no pain on palpation. Fundoscopic exam revealed edema around the optic disc and areas of retinal degeneration, and the eye is non-visual. They said no to glaucoma, and this problem has been around for about 1.5 months. So here is the hemisection of that left eye. Immediately, your eye might be drawn to this very large tan mass that is adhered to the posterior sclera and kind of has this vague, like, cone shape to it, perhaps. This is, let's see, there is the optic nerve head right here. The optic nerve we can't quite see. It's probably just obscured, kind of enveloped by this mass. Other things, so the anterior segment, or like kind of the intraocular structures in general, look pretty unremarkable. We don't quite have the lens. Maybe that's like a little tiny, like, tangential section through it. But we said that it looked normal. Only other thing that we noted was that there was an asteroid hyalosis, all these tiny little kind of white glittery dip dots within the vitreous. Those are asteroid bodies, and I can show those histologically. Okay, so let's look at the eye.
It's interesting to think about, just looking at that gross image, how vision impairment here might not be necessarily just related to any retinal or optic nerve division, but also how the mass compresses the sclera, and all of a sudden everything is pushed forward, right? So it'll be for all of us that they use glasses and contact lenses. That'll be a hard thing to correct when your
severe
back of your eye.
refraction of the light. Yeah, that's a good point. A lot of reasons why this dog would not be able to see. Condenser on. I can do this. There we go.
Yeah.
All right. So this one's definitely not going to fit very well on the subgross, but we can move it around. So cornea is up top. We can see that maybe there's a little bit of extra basophilia along the peripheral retina right here, very superficial. We'll look at that more closely. This is, a very tangential section. We didn't quite get the pupil here. So this is the iris. I imagine this was harder to section just due to the giant mass in the posterior segment. But here's our lens. This is just a sectioning artifact where we've lost most of the nucleus. We have our retina, and then here is our giant mass. We can see a little bit of the nerve. Perhaps we don't quite have the optic nerve head in section, but we at least have some of the nerve that's being just enveloped and compressed by this very large mass. And from here, it looks like a very eosinophilic mass. Like there's just, we don't quite have the basophilia we see with certain like neoplasms, say. It's like lymphoma typically is quite basophilic. This one kind of has a more eosinophilic hue from low power. Like X thing, there we go. So we'll start with the mass, probably the more important part. Let's see if I can get my bearings. There we go. So optic nerve, we have kind of our normal-ish meningeal layer here, and then kind of expanding the outer layer of the meninges. It's Within the orbital adipose tissue, all of these kind of clear vacuoles are adipocytes. And then it's also, in some areas, infiltrating the posterior sclera, as well as the central choroid. And it's composed of a homogeneous population of cells. So this is a neoplasm, as perhaps we may have suspected. And let's see if I can find a good area. There you go. Looking closer.
That's cute.
Yeah. This population of cells, they're kind of polygonal. In some places are more elongate and spindle shaped. And they form these nice little clusters. I might call this a nest as well. Maybe I just like that term. And then other areas where they're kind of making these nice whorls. They're kind of swirling around a center. Move around a little bit just to show this population. It's a pretty consistent pattern they're doing. I just think it's quite pretty. Some places maybe they're doing kind of these vague streams. If we look at them, similar to Gillian's case with the glioma, they are kind of bland cells, so they don't really exhibit much anisocytosis, anisokaryosis, or variation in cell and nuclear size. They have pretty open chromatin. Sometimes we can make out like a distinct nucleolus, and they have a ton of this kind of fibrillar cytoplasm, so that's probably imparting that eosinophilic hue from lower power. And as I cruise around, you might notice it's not a very mitotically active population. I got 2 mitoses for 10 high power fields, and I think I really had to look around to find any. Let's see. And another nice distinguishing feature for these guys, hoping to get them both in view together, is that sometimes they're associated with areas of osseous metaplasia. So this here is mineralized woven bone, as well as chondroid metaplasia. So we also have some islands of cartilage. Go closer. A little bit hard. The mineralization kind of makes it really hard to section this in really well. Oh, it's a little hard. That was intentional, clearly. So this is just pretty well differentiated woven bone. So we have little cells in here that kind of resemble osteocytes embedded within this mineralized osteoid matrix. And then here's our more cartilaginous matrix. So all these features, kind of these bland cells, they're forming these whorls and nests. They're associated with osseous and chondroid metaplasia, and they're also pretty tightly associated with the optic nerve meninges, are all consistent features with a optic nerve meningioma, which from gross examination, that's a really classic look for them. They're usually these tan masses. They're associated with the optic nerve, and they kind of have that cone-shaped appearance just due to the kind of shape of the orbit in the back of the eye. And we can see areas where they do infiltrate the sclera. And then this was kind of a newer feature for me, but we do apparently see cases where they can also be within the choroid. This admittedly kind of freaked me out at first, but it's apparently not associated with any like more malignant behavior than one that doesn't have choroidal involvement.
It'd be interesting to see if that intraocular invasion has anything to do with size.
That's a good point.
'Cause, yeah, you're right. We don't see that very often. But that's the second one that I remember thinking, oh, it's probably just too big and end up being pushed in there just by, looking for some space. But
so we have that. And then unfortunately, we don't quite have the optic nerve head in section, but we do have a nice feature of the retina that we see with these guys often. So here's our retina. We have a pretty distinct outer layers. Our outer nuclear layer, inner nuclear layer look great. This nerve fiber layer, sorry, our inner layer looks kind of raggedy, and that is kind of pale. It looks a little bit torn up. As we're cruising around, you'll notice we really don't have any ganglion cells, which we should be seeing some here and there. I don't know if this was like a former ganglion cell, but there really aren't that many. This nerve fiber layer is just not looking particularly hot. So likely this is a sequela of compression or ischemic injury too on the optic nerve. So we get retrograde injury to the ganglion cell layer and the associated nerve fiber layer, which would also contribute to the fact that this eye was non-visual. And then really the last thing, everything else within this eye looked pretty darn good. So the uveal tract looked nice, the lens looked fine. There was this one area, which I'm assuming was just due to exophthalmos. So in the cornea, we have hyperplasia, some keratinization. of the corneal epithelium. There's a little bit of pigment also within this epithelial layer, which would also make this eye less able to see. There's a lymphoplasmacytic inflammation, so with some lymphocytes in here. Some of these are probably plasma cells, but they're not super distinct. And then also vascularization, as well as maybe some fibroplasia. So this is kind of more normal corneal stroma that's a little lighter. We have this more kind of condensed fibrous layer up here. So all just probably due to chronic exposure associated with exophthalmos. And I said I was going to show asteroid bodies, but in this particular section, I am hard pressed to find any. Perhaps it was in a different slide. All right, well, I will have to leave the mystery alive for you all on that one. I promise this is not the most important feature. Okay, so let's see, PowerPoint. So short and sweet, this one's an orbital meningioma. In dogs, canine orbital meningiomas tend to behave in a benign fashion, so they're not likely to metastasize. They can be really difficult to get clean margins on just due to the anatomic location, the fact they can be like kind of invasive and track along the optic nerve. In this case, the margins were dirty, so we warned about the possibility of recurrence or just spread along the optic nerve. For intracranial meningiomas, there is a WHO grading scheme that's been applied for dogs. We do not apply that for the orbital meningiomas. We assume that most of them tend to behave in a benign fashion. Cool, I think that's it for that one at least. I can move on to my next case. So this is the globe from a 7-year-old male castrated old English sheepdog / standard poodle mix. So an old English sheepadoodle, perhaps.
Picture of that dog.
That's very cute. So he was diagnosed with glaucoma. They said his menstrual response was absent, did have a dazzle reflex present. Direct PLR was sluggish and incomplete. The indirect PLR was absent. He had been treated with a bevy of medications, which maybe I won't read out. Those are kind of the main clinical findings. They did mention that the contralateral eye had been removed in 2020 due to possible foxtail damage or suspected immune-mediated uveitis and secondary glaucoma, which may be relevant for this case. So this is the hemisection from the globe that we got, not the previously enucleated one. I had to go back and dig out the other half, so there's no optic nerve head in this particular picture. I also maybe didn't focus very well on what I wanted to show, which was the choroid back here was just a little bit spotty in areas. So it's a little bit hazy and hard to see, but we can maybe make out these vague circular areas where there's just less pigmentation, a little more tan white. Other things we grossly had mentioned was that this globe was ophthalmic, there was glaucoma, and the vitreous was thin, so maybe a bit of vitreal degeneration. So, grab a slide. Funny shape.
Cassette shaped.
Yeah, it's cassette shaped. We likely squeeze this one into the cassette so we don't have to upgrade to a larger one, which I'm also very guilty of. Okay, I can get my hand to stop shaking, no promises. All right, so we have cornea up top from low power view is not particularly exciting. Really from the subgross view, it's a little hard to make out any of the finer details of what's happening in this globe. We can see perhaps that, focus, there we go. That our uveal tracts, our iris, our ciliary body just look a little more basophilic, just a little busier, like maybe there's more cells in it, maybe. Our choroid is also affected by a similar process, but again, low power, it's a little bit hard to perhaps make that out. So we will show that higher up. And then here's our optic nerve head, which is cupped. So we can corroborate that there is chronic glaucoma in this case. And then our lens kind of got mishmashed around in the globe, like a little snow globe. It's artifactual. Okay, so, oh my gosh, guess. Okay, I don't admittedly have too much to say about this cornea. It's a pretty good looking cornea, so we'll just breeze right past that. Let's start with our angles, actually. I think this is perhaps the worst example, so I'll show the other angles. But there are areas where Descemet's membrane crosses the articorneal angle and kind of has this arborized pattern. They almost look like little finger-like projections. And in this case, there's a lot of inflammation in the iris stroma, which we will address subsequently. So it's a little bit hard to tell where Descemet's membrane is attaching to. There's all these inflammatory cells that are kind of obscuring that process. I'm going to quickly switch over to our gonioslice to get a better view of what's happening there. So here it is. Yeah, it's a little bit hard to tell from this view. Maybe I can go closer. But we still have like kind of those very fine little filiform projections coming off the termination of Descemet's membrane, and they're attaching directly to this slab of tissue. If I go back one, we can maybe convince ourselves that it looks quite a bit like the iris stroma. So we have this iris-like tissue. It's connecting right to Descemet's membrane. We have collapse of our ciliary cleft. We can't really make out the trabecular meshwork. All of this is consistent with goniodysgenesis or pectinate ligament dysplasia, which provides one good reason for why there might be glaucoma in this eye. On top of that, we also have some other fun changes. So as I mentioned, the uveal tract is just a little bit busier. So there's just more cells within really all of the regions of the uvea. So ciliary body, too many cells. As we go back, our choroid is actually probably the most severely affected. One closer, here we go. And there's a pretty consistent cellular infiltrate throughout. So we have a lot of lymphocytes, all of these guys with the round nuclei, not much cytoplasm to be seen. There are some plasma cells in here as well. For some reason, I just can't make out a plasma cell on the screen. And then more importantly, there is also a macrophage population. So all of these cells here, they have these kind of more elongate, sometimes misshapen nuclei, more open chromatin. Let's see if I can find the other areas where they're less distorted, perhaps. There we go. So these guys here are macrophages. And oftentimes they have variable amounts of melanin pigment within their cytoplasm. I'll go up even one more. Maybe. There we go. So all of this dark brown granular material, this is all melanin. So we have some melanin-laden macrophages. And as we move around, so this is the ventral retina, which has a retinal pigmented epithelium layer that has melanin pigment within its cytoplasm. In this case, it's really hard to make out that RPE layer. Here it is maybe, and it lacks pigment, it's attenuated, and there's a lot of areas where it's just not present anymore. Oh my gosh. Kind of just scroll along to show that. And also show more of just these areas with these melanin-laden macrophages. And I'm going to quickly move around to show our ciliary body, show that there's just a similar population up here as well. So lots of melanin-laden macrophages, lymphoplasmacytic inflammation. In some areas, we also have this kind of patchy loss of pigment within kind of the normally pigmented ciliary body epithelium. So maybe these are epithelial cells here and they just have less pigment. Some areas we just can't really make out those epithelial cells anymore. Then lastly, quickly, our optic nerve head and retinal when we're up close. So optic nerve head is definitely cupped, it's atrophied, which is consistent with chronic glaucoma. And then our retina, which I kind of already fanned over. Maybe diminished numbers of ganglion cells. There's still some here and there as we kind of move around. It's less than what we would normally expect to see. And then we also have some disruption of kind of all of our layers. There's areas where it's just full thickness atrophy. Okay, and those are kind of the main findings. So we have goniodysgenesis in this case, but we also on top of that have this pretty robust pan-uveitis, which importantly has a ton of melanin-laden macrophages in areas of depigmentation, all of which is consistent or highly suggestive of VKH-like syndrome or uveodermatologic syndrome. Which, if we go back to the history, they'd mentioned that the other eye had been removed due to possible foxtail damage or suspected immune-mediated uveitis and secondary glaucoma. So we do have a somewhat fitting history. It's interesting that maybe there is asynchronous presentation where one globe had uveitis and now this one does. A little bit hard to say. Maybe there was truly foxtail damage or something else that caused uveitis before these eyes developed uveodermatologic syndrome. But it's kind of an interesting history. Let me go to the diagnoses.
Can I follow up with skin disease?
No. Let's see. They didn't say anything about skin disease. We had mentioned that if there was skin disease, that would help support the diagnosis. But a lot of our cases, there's usually not a concurrent history of skin disease, or it comes later on in time. So yeah, here are our main diagnoses. So signs that are highly consistent with VKH-like syndrome, Goniodysgenesis, as well as chronic glaucoma. In this particular case, there really wasn't much else at the iridocorneal angle besides Goniodysgenesis. So I would be inclined to say this could be just a primary glaucoma. We do also have a uveitis though, which can contribute to glaucoma. So it's a little hard to say if this was also a contributing factor.
Destined for blindness.
Yeah, and in this case, the other is already enucleated, so it's probably semantics.
Right.
I think the other eye was doomed if it was still in the eye regardless, or still in the dog regardless. And those are, yeah, my cases. If there's no other questions, thoughts, then I will give the scope over to Dr. Klimans.
Just a quick thing, we often hit on that those clinical points, but you know, we almost never, well, again, maybe tone down. We rarely get information, either information or when we receive information, they're almost there's rarely signs of cutaneous disease by the time that we receive the eyes. We often receive both eyes at the same time because PKH or this disease tends to be bilateral and symmetrical. And also one thing that we realize too is the variety of dog breeds that develop this disease. You know, if you check the literature, there are some very obviously predisposed dog breeds, but do not rule out VKH in a dog just because of its breed, because we have seen anything from what's again the poodle,
Old English
sheepdog mix to classic, you know, Akitas and etc.
Yeah. Okay. This isn't even our eye. I think I may be able to fit in both cases if I make the short one exceptionally short. So here we go. So this is a 15-year-old neutered male Chihuahua. This is a representative photo that may have looked similar to our Chihuahua. We didn't have a gross photo of our Chihuahua, but I really wanted to show this one. So they say that the right eye had, they say decimetaphyset, so a really deep corneal facet, some other corneal changes, hyphema in the anterior chambers sitting in front of the lens capsule, and they couldn't see anything past that. Long story short. The other eye had a phacoemulsification done, and they note that there was a diminished ERG, or electroretinogram. So they wanted us to assess the retina in this eye to see if we could determine whether what was causing the issues with the retina in the other eye. Sadly, we were unable to do that for reasons that I will reveal shortly.
Yeah, I remember that history.
Yeah, it's not like, oh, bummer. We may not be able to help with that. So in this representative photo, our eye would have had a lens visible, this one didn't. And then what would have probably been similar between our eye and this representative photo is we would have had this discontinuity in the sclera posteriorly. And we have this whitish tissue lining intraocular surfaces. Our eye would probably have been a little bit more crinkled and more white tissue filling the intraocular spaces, essentially intraocular fibrosis. So this is a thesical eye, small, and with evidence suggestive of a rupture in the back. Oops, I don't know why I just did that. I wanted that. All right. A quick subgross.
The history of running with a pencil.
So here's our Chihuahua. You can see the really deep facet up here. At our examined level, it's not quite down to Descemet's membrane, but that might have just been a function of sectioning. And then the main things, we have this area where the sclera is particularly wrinkled. We have all this pink tissue lining that spot and extending into the globe, kind of embracing the lens. We have a really distorted retina, unfortunately, detached and multifocally torn, which is why we were ultimately unable to make a distinction about what was going on with the ERG in the other eye. There's also this purplishness, which is extending in this direction and then kind of up underneath the bulbar conjunctiva right here. All right, promise I would try to make this very short and possibly failing. Here is our facet briefly. You can tell that you have lost corneal stroma because the epithelium is oriented at an acute to sometimes right angles with the existing corneal stromal fibers. And then after losing that stroma, the epithelium slid along that surface and healed up. So this is basically what a facet looks like. A quick example of that. While we don't actually have a discontinuity in the sclera at this point, at our examined level, we do have all of this fibrosis lining the sclera at this point and extending into the globe, which is suggestive of a rupture site somewhere out of plane of section. It's really common for fibrosis to extend from a defect into the globe. We have this fibrosis just dissecting through the retina here. And again, this detached and multifocally torn retina, which makes me sad. We do have some atrophy in this retina, but basically there would be no way to tease apart any pre-existing retinal conditions from what would have been caused by the acquired changes here. But then the main reason why I'm showing this, and because it's just kind of neat, if we check out the posterior lens capsule here, embedded in this fibrosis and surrounded by macrophages in this case, we have a few of these cute little kind of periwinkle bodies. These are asteroid bodies. He's got stars in his eyes. So there you go.
Oh, there they are, yeah.
Yeah. So they're in the vitreous, which is where they would be. They develop in the vitreous. And asteroid bodies are nice in that they tell us where the vitreous is. Sometimes otherwise the vitreous is invisible to our eye histologically. So in this case, if we go next to where our suspected scleral rupture would be, all of a sudden we have this little bluishness outside the eye in the episcleral/orbital tissue. And these are indeed more asteroid bodies outside the eye, further helping to support that this eye did rupture. And we can continue to track them. Wow. Here's some more. And here's some more. And a lot of more. So many more. And we can track them all the way up underneath the bulbar conjunctiva. Wow. Look at them all. They're literally just beneath the conjunctival epithelium in our examined section. I would kind of imagine that this would have been like grossly visible as some sort of a white focus in the conj. So yeah, the vitreous prolapsed quite a ways out of this ruptured eye and essentially went up subconjunctivally. I don't know if that's the word, went up into the subconjunctival area. So that was just kind of neat in a pathologist neat kind of a way. And I wanted to show this case of presumed sequela of ocular trauma to you. For that
There's an
reason.
astronomy related joke somewhere in there about asteroid bodies
Yeah.
being out of the eye like that. But that's
Out of orbit.
That's
pretty good.
This is a good one.
Out of orbit is pretty good.
yeah, orbiting around the eye.
Is Decime's ruptured in this one?
I think it is, yeah. So we got, especially on the same side of the globe, it's kind of folded on itself weirdly and sort of in and out of plane of section, which makes it a bit weird, but I believe, there we go. Here's an
there we
actual discontinuity.
Nice peripheral break.
Yeah,
There you go.
so another evidence of trauma, yeah. So there you go.
The heck of an impact to
Right.
squeeze all those.
Yeah.
You wonder.
Yeah, and every time we see things intraocular material or tissues outside the eye, that strongly suggests a high energy blunt ocular trauma that basically squeezes intraocular content out of the eye.
It's
So-
by meteorite.
Hit by car,
Meteorite.
yeah, hit by baseball,
Yeah.
Meteorite caused the asteroid ones.
right?
Be
hit by an
interesting.
asteroid.
Sometimes we get, so dog bite trauma is usually both penetrating and blunt in
Yeah.
that the bite force can sometimes squeeze the eye. So you get like a, blunt rupture as well as potential penetration, but there wasn't any penetrating injury potentially, but I don't know. Maybe a bite like around the periocular area, squeezing them on the eye tissues. I don't know. It'd be interesting to delve into patient history and wonder whether there was any known suspicion for trauma at some point. Anyway, the asteroid bodies were the main reason why that one is cool. And I can totally fit this case that's longer into 5 minutes. Just watch me.
Go.
Here we go. This is a 6-year-old neutered male Labrador retriever poodle mix, aka Labradoodle. So we have a cloudy cornea. We have a cloudy lens. We have exudate inside the vitreous and aligning a thickened and distorted looking detached retina. And we have this sort of multifocal to coalescing whitish exudate lining the epicroidal surface. I didn't give the actual patient history. They say moderate mucoid discharge, conj hyperemia, absent menace and dazzle, ventrotemporal focus of perilimbal bulbar conjunctival exudate severe. And there's a bunch of fibrin hypopia inside the eye that they can't see past. So that's what they said clinically. All right. So, straight to histo. Bunch of deepers, and I only need the original level, such as like. Oh, it's definitely the corneas. Let's talk about the anterior segment. No, I'm just kidding. So back here in the posterior segment, there's a lot of purple. There's a lot of basophilia, lining a detached retina and the epicoroidal surface. So we've got our exudate inside the eye. And we also do have a bit of basophilia, especially up here in the limbus, where they said that there was a lot of discharge clinically. So there's a little bit of inflammation extending up there. All right. Now the globe is upside down based on how I have it. Let's see. So pointing out that this is an area where there's some cavitation, there was probably some degree of a fistulous or draining tract. You can see it maybe kind of coming out in the conch surface here, so that might explain why there's so much exudate. I don't have the condenser in. This inflammation is mostly at neutrophils and macrophages. And then if we take a look back here, where it's carpeting surfaces, and we have a lovely dot to help us. It's again, mostly macrophages and neutrophils. And I'll tell you that I looked over this original slide very closely and did not find any organisms, but I was strongly suspicious of fungus in this case. This patient comes from California, so I was particularly suspicious of coccidioides, which sometimes we only have like one organism in like a bunch of sections. So I ordered some deepers and a PIS for fungus, and the PIS for fungus came back first. And I realized that I didn't need the deepers. So here's the PAS for fungus, and especially if we traipse along the exudate that's surrounding the retina, we actually do see many fungal organisms already. So here they are, they're round to oval little yeasty beasties. And they are highlighting nicely with the PAS. Interestingly, these guys don't show any sort of peri-yeast clear zone. Essentially, they don't really have much of a capsule to them, which, all right, it's going to be hard for me to find. I said I would be fast. I swear, occasionally you'll find these guys narrow-based budding. So narrow-based budding is Cryptococcus. And usually those guys have a capsule, and in this case, they don't really seem to have much of a capsule, which is a reminder that some Cryptococcus may be capsule deficient, which is fun and a diagnostic challenge. And I'm going to switch over here. So we went back to the H&E after seeing the PAS for fungus, and you can actually spot the yeasty beasties. It's just very difficult. And this one is, if I can get it nicely in focus, showing it off. Yeah. Right here. And it is, if I can maybe convince you, exhibiting narrow-based budding here, a little wee bud there. So they are visible on the H&E, just very hard to pick out. Typically, these guys have a nice big clear halo, which is part of their capsule, but some Cryptococcus may not have a obvious capsule, which may be a diagnostic challenge. Long story short, too late. So this was a case of Cryptococcus causing an ocular disease in a dog, much like Gillian's fungal case. I would be suspicious that this is ocular manifestation of systemic disease. The suspicion is that this patient has systemic cryptococcosis, which is, ball back in the clinical court. So there we go. I did it in 5 minutes.
With that area of the limbus that was so affected, I wonder if it was going to be a penetrating like grass on or
it could be.
And I was like, where's the plant material?
Yeah. So, I mean, it could be a penetrating trauma, even inoculating the fungus into the eye potentially. In this case, I would be more suspicious that it was in to out, basically like a draining tract of sorts. But yeah, it could be a penetrating trauma, even with finding the Cryptococcus.
It was a ninja pigeon.
Yeah,
Yeah.
Poked the dog in the eye.
they had a really like robust like poop, and then it like shot through the air like a dagger.
With a poop encrusted toenail.
Okay. Anyway. All right. So yes. In all
everyone.
seriousness, Cryptococcus. On that note, yes.
You got 2 weeks. You stop.
Oh, yes, I can. I can't stop the record.
Stop share.
Just the stop share button.